So I will be talking today about usefulness of NIRS, near-infrared spectroscopy in clinical decision-making for compromised hemodynamics. And I will be talking more about physiology, not just NIRS as a technique. My objectives for today: first, to introduce the integrated evaluation of hemodynamics, including assessment by near-infrared spectroscopy. Second, to discuss the physiology of oxygen delivery consumption and end organ autoregulation, and how can we use near-infrared spectroscopy to evaluate all of these physiologic aspects. Then applying the integrated assessment of hemodynamics, including assessment by near-infrared spectroscopy on sick infants with compromised hemodynamics, and I have some case scenarios for discussion. So first of all, if we move in our NICU, like my NICU or your neonatal intensive care unit, you can realize that all of the sick infants in the NICU can be categorized into two main categories. So a category with respiratory issue, so at risk or with definite hypoxemic respiratory failure, infant at risk of hypoxemia, and it can be one of these pathophysiologic mechanisms. That's very basic physiology. So limited diffusion, and the main common example for that is infant with chronic lung disease with the thickening of alveolo-capillary membrane. Right to left shunt, and I mean by right to left shunt the intrapulmonary right to left shunt due to significant lung collapse. So the blood shifting from the right to left without getting enough oxygen. Hypoventilation due to high carbon dioxide pressure. Pulmonary congestion, and the best example for that is infant with the PDA, pulmonary hypertension, or VQ mismatch, which is the most common mechanism and pathophysiologic mechanism of hypoxemia in sick preterm and term infants. So that's definitely hypoxemia, which may or may not be presented with hypoxia. So we have infant at risk or with definite hypoxia, and the hypoxia, it means issue with one of the three components responsible to maintain oxygen delivery at the tissue level: blood flow, hemoglobin, and oxygen saturation. So in hypoxemia we have only problem with the oxygen saturation, but in hypoxia can be any one of the three. So severe hypoxemia leading to definite anaerobic metabolism and lack of oxygen delivery at the tissue level, or anemia, or low blood flow, and low blood flow can be low preload, low systemic vascular resistance, the same like septic shock, high afterload, like post-neonatal transition, cardiovascular compromise, or post-PD ligation. Poor myocardial performance, when you have significant poor myocardial performance in absence of high afterload. So the main issue is poor myocardial performance, like cardiomyopathy, one of the most straightforward example, or left-right shunt. So I will discuss in details or some details today how to integrate NIRS in this category. The other category means another separate presentation, talking about acute hypoxemic respiratory failure and the hypoxemia, and how to integrate near-infrared spectroscopy together with pulse oximetry for assessment. So just go through some physiologic details. So we have three main systems responsible to maintain oxygen delivery at the tissue level, and we have multiple levels of compensation to compensate for any issue happen when one of these systems. So we have cardiovascular system responsible to maintain good blood flow, which is carrying hemoglobin and oxygen to the tissue level, and we have hemoglobin, and the relationship between oxygen and hemoglobin should be maintained as per oxygen distribution curve. So the position of oxygen distribution curve also very helpful to understand the oxygen delivery, adequacy of oxygen delivery at the tissue level. And then we have respiratory system, which is responsible for normal uptake of oxygen and maintaining normal oxygen saturation and partial pressure of oxygen. So we have the three systems working all together. and any one of these systems started to decompensate or unable to provide enough function to maintain oxygen delivery, then the first autoregulatory mechanism or first compensatory mechanism is local autoregulation at the tissue level. And the autoregulation is different from organ to organ. So it is very smart at the brain level. It might be less at the kidney or intestine. So it is different from organ to organ. And even at the brain level, it is different from hindbrain to forebrain. So what's autoregulation? Autoregulation is vasodilator mechanism, intrinsic vasodilatation at the tissue level, and it is stimulated by nitric oxide released through RBCs to maintain vasodilatation in case of any one of these organs unable to provide enough oxygen. What happened if the autoregulation reached the maximum and there is no enough autoregulatory mechanism to maintain? So the tissue will try to extract more oxygen, which we call it in physiology increased oxygen extraction or fractional oxygen extraction. At this level, we can evaluate by near-infrared spectroscopy. And if the tissue reached the maximum capacity to extract oxygen, then the next will be anaerobic metabolism and lactic acidosis, or production of lactic acid. So if you have high lactic acid in the blood gases, it means that you have all of these compensatory mechanisms have been lost or exhausted, which is too late. So by applying a technique which can detect the autoregulation or compromised autoregulation, we cannot detect autoregulation in real time. It happens in a fraction of a second, and you need MRA together with the NIRS at the bedside, which is almost impossible to happen at the bedside. So we can use the near-infrared spectroscopy to detect the second mechanism, which once you have it, once you have high fractional oxygen extraction, it means that the autoregulation has been lost. Then you have just one step before anaerobic metabolism, which if the hypoxia or hypoxemia deteriorated more, then the next will be end organ dysfunction and cellular death at the end. Then just to describe in more details the previous slide. With compromised systemic blood flow, the blood flow decreased. And we have some clinical markers like hypotension, oliguria, acidosis, delayed capillary refill, any one of these markers. And if you confirm by echo poor myocardial performance, PD shunt, or increased pulmonary vascular resistance, or low systemic vascular resistance, the next mechanism will be vasodilatation, local vasodilatation at the tissues, which is autoregulation. That's difficult to evaluate in real time. And at this stage, you have fully compensated, full compensation for compromised blood flow. But if the oxygen delivery keep compromised, then the oxygen extraction will be increased to compensate for the decreased blood flow or anemia, for example, or severe hypoxemia. So still this compromised autoregulation, but still compensated. Still you can easily reverse that. But once you have lactic acidosis, you have very short time. If you are unable to reverse the process, the end result might be tissue damage and necrosis. At this stage, you have decreased oxygen consumption, so the NIRS will not be helpful at this stage because the tissue now is necrotic and the extraction now is decreased either back to normal or even very low extraction. The same example for that is infant with HIE, which he's already passed all of these stages in utero before he born with significant decreased oxygen extraction and tissue damage. At the end, you have multiple organ failure, and even the lactic acid is, when started to increase in this stage, will start to decrease at the end because you don't have even capacity to produce lactic acid. So at the significant necrosis, you may have lactic acid start to decrease, which should not be considered as a marker of improvement. Then we have at the end a reversible shock and death. So that's actually decompensated and very bad stage, and we have to try to protect our infants to be in this category, in the latest category. You have to predict early during the first or second stage. So the near-field spectroscopy actually is can be considered as a bridge between the compensated and decompensated stage, when you can predict the compromised autoregulation and you can work more hard and provide more support to reverse the process back to compensated stage. So I marked the first one as green, the second one as yellow, and the last one as black. When you have, even when you have the infant to reverse it back, you may have permanent damage of the tissues. So what's normal hemodynamics? There is no I couldn't find any clear definition of normal hemodynamics in literature. But based on the integrated approach, we can define normal hemodynamics as its integrated ability of cardiovascular dynamics, respiratory physiology, which is providing enough oxygen saturation, oxygen carrying capacity of the blood, which is a hemoglobin, and the relationship between hemoglobin and oxygen, which is maintenance of oxygen dissociation curve at the normal level or normal position. And then the autoregulatory mechanisms, because we may have in very premature infants lost or very weak autoregulation, which might actually affect the brain development significantly if the premature infant exposed to any one of these issues, cardiovascular issue, respiratory issue, or anemia. So the four mechanisms should be able to maintain tissue oxygen enough for normal organ function. That's, in my opinion, the normal hemodynamics. So do we have a standard method of monitoring? Do we have in our unit clinically approved and reliable method of monitoring to give us the answer very clear? So let me discuss as described by Sulaimani et al. 2010, the standard method of monitoring. It should be non-invasive, continuous, available at the bedside, accurate, real-time, reliable with quantitative results that can be directly interpreted in physiological terms, leading to a formulated medical decision. So which kind of monitor can be consistent with this definition? So the question now to you, do you know any kind of gold standard monitoring consistent with this definition?
We don't know, but it looks like very idealistic definition.
Yeah, so such kind of standard monitoring does not exist in reality. Does not exist in our world so far. You for example, target neonatal echo. If you consider that that's very helpful technique, it is non-invasive but not continuous. So you are evaluating the infant by TN echo at the bedside. It's longitudinal one-time evaluation, and then 1 hour or 2 hours later you may have everything changed, and you cannot keep performing echo 24 hours. So it is not like kind of non-continuous. So TN echo does not apply to this definition. What about NIRS? NIRS is non-invasive, continuous at the bedside, but cannot give you directly interpreted physiological terms, cannot let you know that this infant is anemic, you need to transfuse, but can give you a trend that this infant is compromised, the autoregulation is compromised. So can give you just a general idea about something wrong is going on and you have to help. So by relying on just one modality or one technique cannot give you the clear answer. So that's the idea of integration. We are integrating between different modalities to make the picture more clear and more reliable, to compensate for non-existence of such standard method of monitoring. So we're trying to get the benefit of TN echo plus the benefit of NIRS plus the benefit from clinical assessment, which is on top of everything, to get a picture more clear. And dealing with the clinical assessment should be physiologic assessment. For example, blood pressure dealing with systolic and diastolic plus the pulse pressure difference, not just mean blood pressure, which does not give you a very physiologic idea about what's going on. So that's why we thought about dividing the levels of hemodynamics, because we cannot teach everyone in NICU, like physicians, nurse practitioners, nursing staff, the details of hemodynamics, but we can divide that into levels. So level 1, relying on blood pressure trends, systole and diastole, pulse pressure, that can be applicable and can be educated to all NICU practitioners. So like for example in Winnipeg, I'm working on that. Even bedside nurse can know how to check the blood pressure trend, systole and diastole plus pulse pressure, and she can notify the physician early about any change in the trend. Then level 1 plus, if you have near-field spectroscopy, you can correlate between blood pressure and NIRS, and you can get more clear idea about autoregulation, and I will show you an evidence for that. Level 2, when you have TN echo approach, then you can get more idea about the cardiovascular hemodynamics, intracardiac shunts, pulmonary arterial pressure, and myocardial performance, so you have more insight view about cardiovascular assessment. To be honest, when we started to rely on the blood pressure trends, we found that we can avoid unnecessary consultation for TN echo. So you can select the most appropriate cardiovascular medication, either vasopressor or inotropes, just based on the trend, without escalating that to TN echo. And but at the end, you may have some complex cases that you may need to do a TN echo for sure. And then at the end, some complex cases you may need to integrate NIRS and the TN echo and everything to make the picture more clear. So the last level, which is level 3, I will focus on that in this presentation, and I will give you just some case scenarios when we performed echo, but when we applied also near-field spectroscopy, the picture became more clear and more helpful to formulate a clear medical recommendation and a change of management plan at the end. Okay, so let's start with the idea of applying near-field spectroscopy. You have at the bedside the pulse oximetry, which give you the arterial oxygen saturation. So we know how much reaching the tissues, how much can be available as a tissue level, as a saturation, but we don't know how much can be consumed or being consumed by the tissues, which is the other part of the picture, hidden from us. But if we have near-field spectroscopy, you have the picture more clear now. So near-field spectroscopy giving you a number, 65, which is comparable to the venous saturation. So it is definitely how much left over after the tissue consumed, the difference between both. So the difference between 97 and 65 is how much consumed, which is between 20 to 30% in most of the tissues. So when we have this number very high, like almost 95 or close to this number, it means that the tissue is necrotic and the tissue does not consume any oxygen. But if you have this number very low, it means that the tissue is extracting more, compensating for lost autoregulation. So you have both extremes, and in between you have the normal range. So the normal range usually between 60 to 80, and I'm coming to explain that in more details. So the idea of NIRS, that technique or the idea of near-field spectroscopy, just relying on near-infrared light source, which is passing through the tissues and reflected back on a photo detector, and the photo detector can detect the ratio between the oxygenated and deoxygenated, so just receiving what's oxygenated fraction from the tissues. And as you know, in any tissue we have 80% of the blood in any tissue venous, 15% arterial, and 5% only capillary. So it is mixed, to be honest. It's mixed between arterial and venous, but what they did actually in the machine, they calibrated the machine to detect mainly the venous fraction in the tissues. So the number that you have, it is equivalent to the mixed venous blood. And the mixed venous blood, if you able to get the mixed venous blood invasive, you need to get a sample from pulmonary artery, which is really difficult and almost impossible in neonate. In adults, in some neonates is still relying on a pulmonary artery catheter to get the mixed venous blood sample and correlate that with the arterial sample and get an impression about blood flow or the oxygen consumption. One of the nice literature about combined use of blood pressure and NIRS, and they relied actually on the mean arterial pressure less than gestational age, which is one of the old definitions or old reliable methods for blood pressure. So in this literature, they concluded that mean blood pressure less than gestational age was not associated with either lower brain tissue oxygenation index, which is a number given by NIRS, or with lower neurodevelopmental outcome scores at 18 months of age. However, regardless of the blood pressure, the low tissue oxygenation index, which is a number given by NIRS, was associated with lower neurodevelopmental outcome scores. So you may have low blood pressure less than gestational age with still maintained autoregulation and maintained blood flow. But the number on near-infrared spectroscopy definitely will give you an impression about lost autoregulation and decreased blood flow at the below the threshold of the autoregulation. Then we'll shift to oxygen delivery. Now we know the idea of oxygen consumption by relying on near-infrared spectroscopy plus the pulse oximetry. Oxygen delivery as the tissues, it is the product of blood flow and oxygen content of the blood. And the oxygen content, it is the saturation and the hemoglobin. So when you have the saturation, you just have a small part of the total picture. The blood flow, which is the product of heart rate multiplied by stroke volume, and you can get that by echocardiography, or you can calculate that in a different method by echocardiography as well. So you need to calculate oxygen delivery, target natal echo for cardiac output, and you need hemoglobin and saturation. And the equation is easy. So cardiac output multiplied by 1.39 multiplied by hemoglobin gram per ml, because everything in unit is per ml. So if you have hemoglobin 125, it should be 0.125 milligram per ml multiplied by saturation as a fraction. You will get the oxygen delivery at the end. That's easy equation. You can apply it at the bedside if you have the cardiac output calculated by echo. And then fractional oxygen extraction. That's also an easy equation. Once we have a NIRS machine, you can calculate how much consumed by the tissues out of the arterial saturation. So the equation, arterial saturation minus the mixed venous saturation, if you have it invasive, or the number that reflected on NIRS machine divided back onto the arterial saturation. You will get the fractional oxygen extraction as a fraction of 1. The normal between 0.15 to 0.33. That's in the literature.
Yeah, sir.
Yes.
Kumar here.
Yeah.
So the normal values you're quoting, are they neonatal values, or what is the basis of the normal values?
Okay. So the numbers reflected on the fractional oxygen extraction between 0.15 to 0.33. To be honest, this has been validated in adult and pediatric literature. But the values that here we have validated in Winnipeg in units, it is between 60 to 80. In adult literature, between 58 to 85.
Yeah.
It is more wide in adult. But what we have published trends of NIRS, and we are actually in a process of publishing another article with more difference between the normal trends in normal neonate and also the trend in sick neonates. So we started to rely on 60 to 80%, so more narrow. What has been published in adult and pediatric, 55 to 85. For fractional oxygen extraction, we have different numbers in our literature. But I can share with you like the published articles, and hopefully we have a more detailed one will be published soon. About the oxygen delivery, it's between 20 to 40 ml per kg per minute. You may have it very high in case if you have polycythemia, because hemoglobin is part of it. Or when you have high cardiac output, like in PDA, or if you have infant with a septic shock with higher hyperdynamic heart and high cardiac output failure, you have this number very high. So it is more helpful if you have case of, for example, anemia or low cardiac output. Like, you will give you a clear idea about the decreased or compromised oxygen delivery. And I will talk about the application of that in case scenarios. The regional cerebral oxygen saturation. So I will be focusing on cerebral oxygen saturation in this slide. So when you have low tissue oxygen index, which is a number reflected on NIRS, at the same time you have high fractional oxygen extraction, higher than 0.33, you just accept that for now as a cut limit for normal. Then think about one of these differential diagnoses, like PDA with significant steal of blood from systemic circulation, PDA during ligation and shortly after ligation. Lack of autoregulation, as we described before, because autoregulation is a step ahead before increased oxygen extraction. Hypocapnia, which is more significant and more impact on increased extraction more than hypotension. When you have low CO2, less than 40 millimeter mercury, you can significantly compromise the blood flow by having washed CO2. So don't sleep on that. If you have low CO2, that significantly impact the brain blood flow. So decreased CO2 by 1 millimeter mercury below normal can decrease, and that's like validated in literature, brain blood flow by 4 ml per kg per minute, compared to low blood pressure below the autoregulation threshold, decreased by 1 ml, 1 millimeter mercury of blood pressure may decrease just 1 ml of brain blood flow. So the impact of hypocapnia even more severe on brain blood flow in comparison to hypotension. And then anemia. For sure, when you have anemia, you have low oxygen delivery, so the tissue will extract more oxygen to compensate for anemia. Or high mean aerobic pressure. When you have, mean aerobic pressure. When you have mean aerobic pressure high enough and compromising the venous return, you may have also high oxygen extraction. On the other side, when you have oxygen therapy, it's validated or known in literature as a factor which might decrease oxygen consumption. When you have significant high oxygen in inspired oxygen fraction higher than 0.5, you may compromise the oxygen consumption, not improve the oxygen consumption. You may have that in PBHN, in chronic lung disease, apneas, prenatal asphyxia, or hypercapnia. In this slide is a three-dimensional slide. So to augment everything related to oxygen delivery and consumption extraction on one slide. So we have in this slide the horizontal lower axis representing oxygen delivery in ml per kg per minute, vertical axis oxygen consumption in ml per kg per minute, and upper x-axis representing the fractional oxygen extraction as percent. So we have the normal box here when you have normal oxygen delivery and normal oxygen consumption, which is between 4 to 8 ml per kg per minute in most of the organs, and you have extraction between 0.15 to 0.33. In case if you have low oxygen delivery because of the anemia or hypoxemia or low cardiac output, any one of these three components responsible for maintaining oxygen delivery, any one or more decreasing, then the oxygen delivery for sure will be decreasing, so the tissue will extract more to maintain normal consumption. So decreasing delivery with increasing extraction, and the increasing extraction is a compensation to maintain normal consumption, but that can be up to a limit. So that once you have 60% increased extraction, the tissue cannot extract or increase more than that. Then that's a limit of lactic acidosis. With more decreasing oxygen delivery, the extraction cannot be increased anymore, and then the consumption will be decreased with production of lactic acid. So that's actually very severe and very critical part. So if you have lactic acid, you are almost at the end. So zone 1 is a normal zone, zone C, which is compensatory zone, and then zone D, which is a disaster zone. When you have very low consumption lactic acid, you are just at the edge of tissue necrosis. But if you what's the case if you have normal delivery or even high delivery but low extraction? So that's typical of HIE. When you have maybe normal cardiac output or close to normal, you have normal hemoglobin and normal saturation, but you have very necrotic tissue. So once you recover from the zone D, you may proceed to zone B, which is you have now necrotic tissue and the consumption now is decreased with low extraction. Any question about this slide?
No, actually it's fantastic. It's very clear. Thanks.
Okay, very good. So now in this slide I will start with the clinical applications of near-infrared spectroscopy. So as we described in physiology, first slide, we have infant at risk of hypoxia or infant at risk of hypoxemia. So we have two main categories of sick infants in an ICU. The first category, you may have compromised systemic circulation with hypotension, compromised systemic circulation with normal blood pressure, and I have example for that. So blood pressure is not everything for compromised systemic circulation. Or if you have HIE, who's already compromised everything in utero before birth, and you have severe anemia, or PD or post-PD ligation. So if you have any one of these, it could be a good application to understand the autoregulation and to compromise the blood flow oxygen consumption by applying NIRS. And you may have the compromise actually regional in case of neck, necrotizing tuberculosis, or renal hyperperfusion of the kidney. So you can apply NIRS on the abdomen or kidney to predict the regional compromised blood flow. And you can use the brain as, in this case, as a reference. So you may have normal brain oxygen consumption by NIRS, and you have big difference between the brain and the other organ like abdomen or renal, so it can give you an idea about the difference between both organs. And the NIRS can be connected to up to 6 different organs at the same time. If you have infant at risk of hypoxemia, assessment the impact of desaturation on the brain autoregulation. So we are also using NIRS to assess infant with acute respiratory failure, to assess the impact of frequent desaturation on the brain autoregulation. And also it's very helpful in weaning oxygen in an infant with hypoxemic respiratory failure. So if you have infant on high oxygen fraction, higher than 50%, we assess the brain autoregulation by NIRS, and we use at the same time to wean oxygen back to the acceptable level below 50% by using combined NIRS and pulse oximetry at the same time. Optimize cerebral oxygen consumption in infants with hypoxemic respiratory failure. As I mentioned before, it has been described in the literature that high oxygen, inspired oxygen fraction, will significantly compromise oxygen consumption by tissues, and it will actually worsen the vascular systemic vascular resistance and pulmonary vascular resistance. So high oxygen fraction might actually impact development of chronic pulmonary hypertension, not the opposite. and also it might impact the development of hypertension in premature infants with chronic lung disease, because it is increasing both systemic and pulmonary vascular resistance. That's why having infant on high oxygen for a long time, that's very dangerous and impact every organ in his body. Just to show you in this slide how we integrate ultrasound and NIRS. For example, in this example, we have I'm evaluating intestine by NIRS and ultrasound at the same time. That's a new technique that we are using and relying on X-ray for assessment of neck or compromised intestinal performance. In this video here, you have NIRS applied, and the NIRS wave is passing through a fluid in the colon, and in this case will give you unreliable number. That's one of the limitations of NIRS. You have to be sure that the NIRS is passing through tissues, so you can get impression about the area that you are evaluating in the abdomen by ultrasound, to be sure that you are evaluating tissues, not just a fluid or poop or anything give you an artifact number on the machine, and you're just evaluating the real tissues. So that's ultrasound guided near-field spectroscopy technique. So first one is right approach, second one is wrong. It will give you very abnormal number, unreliable number. So
I like this approach. I mean, do you think that will address the criticism for abdominal NIRS? Many times people say abdominal NIRS, you don't know what tissue you're measuring, right? And that's exactly the common criticism, right?
Yes. So we are compensating for that, because one of the criticism, as you mentioned, that when you apply NIRS, you are not sure if you are putting if the NIRS infrared wave is passing through poops or passing through fluids or passing through peritoneal fluid. You have to be sure that the ultrasound giving you impression that you are exactly over the tissues and you are evaluating real tissues. Then I will start with the case scenarios. Case number one: preterm male infant born at 25 weeks, birth weight 620. The clinical course was complicated by development of neck, stage 3, required ileal resection with ileostomy. He developed post-operative anuria, so he went to OR for ileostomy, and he came from OR with anuria, with normal blood pressure and significant edema due to third space losses. So he developed significant edema, again normal blood pressure but anuria, despite administration of diuretics for 24 hours. So our colleagues in the unit consulted nephrologist, and the nephrologist recommended to start diuretics to move the fluids from the third space through the kidney and improve edema. So I'm gonna show and there was no any improvement for 24 hours. So after 24 hours, because of the continued anuria, and they did not consider significant compromise the blood flow, because the blood pressure maintained within normal in this case. So they asked help from hemodynamics team to assess. So the heart view. So that's actually just a picture, and I have the next one as a video. So you have 4-chamber view, severe underfilling of the heart. I can see only tissues. I can see the black area of the blood filling the ventricle. So the atria, both atria like reasonably filled, but that's at the end of systole. You don't have any blood left in the ventricle. So I just freezed the image at the end of systole. I can see only myocardium. I cannot see any fluid inside the heart. So that's severe underfilling of the heart. And there's the parasternal long axis view. As you can see, at the end of diastole and the end of systole, there's nothing left over inside the ventricle. So that's severe underfilling, and it should be very clear at the end of systole, because if you have underfilling in both systole and diastole, that's actually a picture of dying or died infant. So it should be some filling in diastole, but at the end of systole, that heart is trying to compensate by evacuating almost the entire volume inside the ventricle. And you have some also precardial effusion. That's part of the third space. So we did the integrated evaluation in this case, including cardiac output, which was low, or borderline, you can say. Blood pressure is reasonable. Even the pulse pressure was maintained because the stroke volume was within acceptable limit in spite of lowish cardiac output. And you have systemic vascular resistance actually high. It's normal between 150 to 200. That's a calculated number based on the cardiac output and the mean blood pressure. So systemic vascular resistance is kind of high, and that's very common to have this number high in infant with depleted vascular volume. Because, yes, go ahead.
We just have a question. The SVR you calculated, usually it's an invasive calculation. Is it a non-invasive methodology?
Yes. So systemic vascular resistance is based on mean blood pressure divided by the cardiac output. The cardiac output that you can get from the echocardiography. So it is a non-invasive way of measurement. And physiologically, systemic vascular resistance expected to be increased if you have volume depletion. So the body will try to vasoconstrict more the blood vessels to compensate for the depleted blood volume or volume in the body. You have heart rate maintained, hemoglobin was okay, and you have the left ventricle end systolic volume severely decreased, and we compare that to the normalized value for the gestational age and body weight. And then look at the NIRS value. So cerebral tissue oxygenation index was 52, again supposed to be 60 to 80. So the brain blood flow was compromised autoregulation. And look at the renal fractional oxygen extraction, which is supposed to be 0.15 to 0.33, 0.5. So you have severe compromise of renal function, not yet at the stage of necrosis or lost function. So the kidney trying to compensate, but there is no urine output, but trying to compensate to maybe maintain the intravascular volume. Oxygen delivery was 16, which is borderline against 20 to 40 is a normal, so that's low because of the low cardiac output. And against cerebral fractional oxygen extraction was high. Lactic acid was maintained. So by applying you remember one of the first few slides, the stages of compensation. So this infant was at a stage of lost autoregulation, compromised autoregulation, increased oxygen extraction, but not yet at the stage of necrosis or lactic acidosis. So we are still okay, but we need to know how to compensate and how to improve the hemodynamics in this infant. So that's the results of integrated evaluation. So it is very clear that the infant is hypovolemic. It is very clear that this infant has compromised autoregulation with increased oxygen extraction. No hypoxia or end organ dysfunction at this time. And we are expecting that the renal function can be recovered because it's still extracting a lot of oxygen, and the anuria just to compensate for intravascular volume, depleted intravascular volume. So what's your recommendation in this case? Instead of giving diuretics. So for sure I asked the teams, please stop giving diuretics, and the nephrologist accepted my recommendation. Another recommendation to consider, just marking the most important markers in the integrated assessment. Fluid management, just give fluids, you don't have to do anything else. In spite of severe edema, you need to replace the lost or depleted intravascular volume by giving fluids until the capillary leak or capillary inflammation leading to capillary leak improved, and might take up to 2 to 3 days, and you can help that with the steroids. So giving fluids and the steroids at the same time, and there is no any cardiovascular medication used. There is no dopamine, no dobutamine, and the infant recovered in 48 hours. So it started to pass urine in 48 hours with recovered intravascular volume and also the intracardiac volume. And I have made this actually check mark just to be sure that we did not miss anything. Just to included all of the items of the integrated evaluation. So we have compromised autoregulation in this infant. We don't have hypoxia yet. The lactic acid was maintained with the normal. There's no hypoxemia, but there was compromised autoregulation, hypovolemia, low oxygen delivery, and compromised kidney. And I have this table here explaining that formulated medical recommendation was totally changed after the integrated assessment to just fluids, avoid giving any troops. Giving any troops an empty heart is a disaster. So assume that if you give... Yes, go ahead.
If you didn't have the NIRS, would we still have come to the same conclusion?
That's very good questions. So if I don't have any a NIRS in this case, I may consider the same conclusion, and I may consider the same formulated medical recommendation. But remember that having a NIRS may not actually change your management plan significantly, but give you an answer about the compensation. Let you know that the infant is still compensated and is still recoverable, and you are not yet at the stage of necrosis.
Yes.
So it is kind of monitoring. You are monitoring the organ function and reassure you about the kidney still working well, still extracting more oxygen. There is no renal failure at this stage, and you're still very recoverable once you augment the intravascular volume. That's a very good question. So lessons from this case, in my opinion: loss of intravascular volume is common in GI surgery due to intraoperative loss of third space and third space losses as well. If blood pressure and heart performance are acceptable, management should be focused on fluid management in this case. Then I will shift because I have to finish in time. So I have another case scenario. So I just let me move more quickly. So I have 26-week preterm male infant born after an eventual delivery, birth weight for 840 grams. Was PTA, large PTA treated, and the follow-up confirmed construction of the ductus. No issue until now, but a few weeks later, the PTA reopened, and the respiratory support was maintained, CPAP of 7, but urine output significantly dropped. That's typical for a chamber view for PDA. You have dilated left side of the heart, dilated left atrium, left ventricle, and very dilated pulmonary veins. And you have significant ductus, short axis view. Again, long axis view, you have a dilated left atrium compared to aorta. And when we evaluated the kidney in this case, there was a reversed diastolic flow. And then when we applied the integrated assessment, we found that in spite of this infant maintained on CPAP, there was no significant respiratory failure, but the kidney was significantly compromised. So look at the renal fractional oxygen extraction, 0.45, compared to cerebral oxygen extraction, which was maintained was normal, 0.16. And the tissue oxygen saturation of the brain was 78, so that's maintained between 60 and 80, but the renal saturation was just 51, that's below normal. Borderline mesenteric, 62. So the mesenteric was compromised, but still maintained with the normal. So the only significantly affected organ was kidney. There was actually a debate about this infant. Would we just wait more time, give maybe diuretics, and try another non-steroidal anti-inflammatory drug in this case or not? So actually tried one dose of ibuprofen and the creatinine went up. So with this picture, we decided to consider significant emergency ligation of the ductus to save his kidney. So this gives you an impression that the kidney is really compromised, not at the stage of real failure, and is recoverable. But if you wait more time, it might proceed to significant failure. And you can see here, at the same time, the systolic blood pressure was significantly low. So, like most of the organs were compensated well, but the kidney lost the compensation, lost the autoregulation, and at the edge of failure. So we just consider urgent PD ligation, and within 6 hours, the urine output improved to normal in this case. So if we use a check mark, compromised autoregulation for the kidney, left to right stealing of blood, and the kidney compromise, and there is no any other organ. And we believe that by considering the urgent PD ligation, we save the kidney to proceed to the maybe kidney damage or end organ failure. Gut was borderline compromised in this case. Lessons: PD can lead to renal failure in rare cases without significant impact on respiratory function. For the last 4 years, we had 2 cases with a similar scenario. Infant was both of them were on CPAP, no significant respiratory support, but both of them developed significant renal failure. This is one of the absolute indications for PD ligation in our guidelines. I have case number 3, and I should be finished in 5 minutes, and hopefully I will give you another 5 minutes for discussion. Preterm female infant, 31 weeks, born with congenital heart block. Heart rate 50 to 55 beat per minute. And this infant went to Sick Hospital for pacemaker insertion. And the infant came back without pacemaker insertion. So he went with a trip, very costly trip to Sick Hospital, and came back without pacemaker insertion. Because they consider that 50 to 55 can be acceptable without any end organ compromise. So the absolute number is 50, below 50 beat per minute, or end organ compromise. Then he developed multiple events of bloody stool at 43 days of age with normal X-ray. So the X-ray was normal. The infant was otherwise stable in level 2. Nursery hemoglobin was 82, and that's expected in chronic baby. Stable, and lactic acid was 2.3 millimole per deciliter. So would you change the management in this case based on the clinical details? Okay, so I'll give you more details. So we did the integrated near-infrared spectroscopy and ultrasound. And what we found in the near-infrared spectroscopy, there's actually the report integrating both the ultrasound of the intestine, which showed actually abnormal color pattern with hyperemia. At the same time, showed some sloughed mucosa of the colon. And near-infrared spectroscopy shows significant low tissue oxygen index in the right side of the abdomen. It was between 50 to 55, more than the left. And when we calculated the oxygen delivery, was actually 10, just 10 ml per kg per minute, based on the hemoglobin and the cardiac output. Remember, the cardiac output is a product of stroke volume and heart rate. So the heart rate was just 50 to 55. So that's the final conclusion in the report. Impression of compensated chronic ischemia affecting right bowel more than the left, with compensatory hyperemia. Bleeding might be due to necrotic mucosal sloughing. With the integrated assessment, critical low oxygen delivery, compromised renal and mesenteric autoregulation. We have very significant compromise of the both borderline hemoglobin in this case, and also very low cardiac output because of the low heart rate. So we have oxygen delivery of 10. That's a borderline of between compensation and lactic acidosis. And we have renal fractional oxygen extraction close to 0.5, and mesenteric is 0.5. And you have heart rate of 50, hemoglobin of 83, as we mentioned. So the formulated medical recommendation based on our assessment decision was to treat as NIC, maintain hemoglobin to 110. So when we calculated oxygen delivery in this case, we found that to keep the oxygen delivery in the safe side, the hemoglobin should be around 110, was considering heart rate of 50 to 55, until we get the infant sent back to sick kid hospital for pacemaker insertion. So before transfusion, the first transfusion, the oxygen delivery was only 10. You are exactly, literally at the age of developing lactic acidosis. And after the first transfusion, the oxygen delivery improved to 14. And the hemoglobin improved to 110. And in this area here, you have compensation, but at least you are a little bit away from the disaster area with lactic acidosis and tissue damage. So we suggested to keep the hemoglobin at 110 and give the gut a chance to recover 5 to 7 days with MPO because of the mucosa sloughing, and feeding restarted again after that without any repair of the bloody stool. And our team, they used the report that I showed to you before to convince the team at sick kid hospital to consider pacemaker, and the pacemaker inserted within a couple of weeks from the assessment. So I think that's a really significant impact on the management in this case. Calculating components of oxygen delivery altogether was helpful to diagnose the chronic ischemia and to protect the infant from proceed from compensation to the decompensated stage with lactic acidosis. The common organ affected in this case, as documented by near-infrared spectroscopy, both organs were intestine and kidneys. So that's impact. We have this article, and we evaluated the impact of our approach over 2 years compared to another 2 years before starting our integrated approach. And the main impact was reduction of time to clinical recovery. You can see the almost half of the time to clinical recovery, and non-significant reduction in the trend of deaths between two epochs. But remember the small number. Conclusion: integrated evaluation of hemodynamics is a physiologic analysis of all respiratory cardiovascular markers, systemic regional organ indices, aiming to understand the pathophysiologic mechanism of hypoxemia and the stage of compensation. Near-infrared spectroscopy is useful as a adjuvant tool in the integrated assessment. So you cannot use it in separate. You have to use it, or you have to consider it as just part of the picture, part of the integrated assessment. This should lead to formulating a physiologic-based medical recommendation. So thank you, and I think I have maybe a few minutes for questions.